Welcome back, coders, to part 48 of our 100-part CPC exam series. I'm Harshal, and in today's explainer, we are jumping right into the ultimate point savers for your test, compliance and regulatory guidelines. We're going to break down exactly what you need to know, but before we decode these exam traps, make sure to like, share, and subscribe to Decode Healthcare with Harshal. Let's get to work. Here's our agenda for today. We're looking at a compliance overview, OIG guidance, decoding NCC edits, HIPAA, OSHA, and CLIA, medical necessity, and the ABN, and then we'll wrap it all up with the cheat sheet.
All right, Section 1, Healthcare Compliance Overview.
Now, compliance isn't just a bunch of boring legal jargon. It's literally the foundation for preventing fraud, abuse, and waste in billing. You might be wondering, why do we care so much for the exam? Well, because about 3 to 4% of the CPC exam zeroes in directly on how well you know these specific billing rules. Knowing your audit triggers doesn't just protect a practice from massive fines in the real world, it absolutely protects your score on test day. Moving right along to Section 2, OIG and Compliance Guidance. So, the Office of Inspector General, or OIG, publishes what's called the OIG Work Plan. It's updated annually and monthly, and you can think of it like a giant radar that identifies high-risk billing areas targeted for federal audits. If the OIG announces they're targeting a specific service line, smart coders know they need to immediately step up their internal auditing for those codes. You definitely want to avoid that spotlight. Listen up, because this is a massive exam trap. Under the False Claims Act and the Anti-Kickback Statute, you have to know the difference between fraud and abuse. Fraud requires intentional deception. That's like billing for a surgery the doctor never actually performed. Abuse, on the other hand, is an unintentional mistake or a practice inconsistent with sound fiscal rules, like, say, routinely upcoding an EM visit just because you misunderstood the guidelines. Intent is the dividing line here. To prevent that fraud and abuse, the OIG mandates these 7 core elements for an effective compliance program. Think of it as a practice's immune system. You establish written policies, you assign a compliance officer, train your staff, keep communication open, audit the work, enforce disciplinary standards, and if an offense happens, you respond promptly before it turns into a total federal nightmare. Let's dive into Section 3, Decoding NCCI Edits.
The National Correct Coding Initiative, or NCCI, uses procedure-to-procedure, or PTP edits to stop improper payments. The rule here is super simple. Column 2 component codes get bundled into Column 1 comprehensive codes. For example, if you code a major surgery, you can't separately bill for the minor surgical approach. It's bundled. You literally cannot bill them separately unless a clinically distinct service justifies using a modifier.
So how do you know if you can bypass that edit with a modifier? You look at the NCCI modifier indicator. If you see a 0, you absolutely cannot unbundle that code pair. No exceptions. But if the indicator is a 1, you're allowed to append a modifier, like 59, or the specific X modifiers, XE, XS, XP, or XU, if and only if your clinical documentation proves it was a completely distinct separate service. The NCCI also enforces medically unlikely edits, or MUEs. This is strictly about unit limits, not code pairing. It defines the absolute maximum units of a service you can report under normal circumstances for a single patient on a single day. For instance, billing for the removal of 3 appendices on 1 patient? Yeah, that's going to trigger an MUE and an automatic denial. You only get 1 appendix.
All right, Section 4, HIPAA, OSHA, and CLIA.
For HIPAA, you've got to memorize these 3 rules. The privacy rule protects standard protected health information, or PHI. The security rule safeguards electronic PHI, and definitely watch out for the minimum necessary rule on the exam. It states you should only ever access the absolute minimum information needed to do your job. A biller doesn't need to read a patient's psychotherapy notes just to submit a claim, right? Please don't mix these 2 up on test day. OSHA is all about workplace safety for clinical staff. We're talking bloodborne pathogens, exposure control plans, and personal protective equipment. CLIA, on the other hand, is strictly about laboratory quality. If a test question mentions waived tests or moderate to high complexity lab work, the answer is always CLIA. Next up, Section 5, Medical Necessity and ABN. Medical necessity is basically the glue of coding. It means you're linking the correct ICD-10-CM diagnosis code to your CPT or HCPCS procedure code to prove the service was actually reasonable and necessary. Even if you coded a surgical procedure absolutely flawlessly, That claim is getting denied if the diagnosis code doesn't clearly establish medical necessity. Now, what if you suspect Medicare is going to deny a service because it lacks medical necessity? You must issue an Advance Beneficiary Notice, or ABN. That's Form CMS R131. And you have to do this before you perform the service. This is critical because it legally shifts the financial liability away from your practice and directly to the patient. When you're dealing with ABNs, you have to know these modifiers. The GA modifier means the ABN is signed and on file. Just think, got it all signed. The GZ modifier means you expect a denial, but you have zero ABN on file. Seriously, do not mix these up on exam day. And finally, Section 6, the cheat sheet outro. Get your cameras ready and screenshot this right now. These are your 5 golden rules for the exam. Fraud requires intent. Abuse is a mistake. The OIG work plan equals audit targets. NCCI indicator 0 means no modifier. 1 means you can unbundle if it's distinct. HIPAA is privacy. OSHA is safety. CLIA is labs. And finally, GA means you got it all signed. GZ means 0 ABN. You are getting so close to crushing the CPC exam. I really hope this explainer helped clear up the regulatory maze for you. Keep decoding, keep studying, and keep pushing forward. But wait, we're not done yet. Next up in Part 49, we're tackling the absolute beast, evaluation and management. Are you ready to master E&M coding guidelines, medical decision-making, and those tricky time-based rules for office and outpatient visits? You won't want to miss it. I'll see you in the next explainer.